Hello guys and welcome. So today we have Joe joining us yet again. So we're going to be doing this in two different parts. Today will be the first part, Friday will be the second. Today we're going to be talking about the plan of care and how the PTA implements the plan of care from the PT, as well as what we can do if things we want to do aren't in the plan of care and just kind of working on those communication skills. But let's go ahead and jump right in. You're listening to the PT Assistants podcast with your hosts, Ken
and Laura. Thanks for joining for another exciting episode. Yeah, well, first we want to congratulate you, though, because he told us something right before we got on. And I think it's really important that we should bring it up. But Joe is hitting 10 years. Is it today, technically?
It's on the 15th of January.
It's on the 15th? Yeah. And so we wanted to say congrats because that's big. That's honestly, I feel like that's huge in the medical field because so many people burn out sometimes before even hitting like 5 years. Making it 10 years is awesome, and congrats to you for that. And just how are you doing real quick on everything?
Me? I'm doing, you mentioned like making it 10 years and whatnot. It is a huge milestone. Without hitting burnout, I definitely hit burnout in my career and compassion fatigue a few times. Just soldiering through that has been kind of tough, but I think that just comes with the career field that we chose, dealing with people and the complexity of dealing with injured people, sick people, so people that want our help. But I'm doing great. I'm glad that I've been in this field for as long as I am. I'm glad that, I'm still around.
We're also glad.
You're still
We're
going.
very, very glad.
Still going. Here we go.
We're glad that you're willing to share all that knowledge with us, which is amazing too. So
yeah, and I appreciate what you guys are continuing to do here because PTA field, you guys are definitely uplifting it and advocating just by getting our voices out there, and that's super important because in my 10 years, I've seen my classmates. I think I graduated like 30, 32. I can tell you that more than half of them don't even practice physical therapy anymore. And that was within probably the first 2 to 3 years that most of them left the career field. So it's kind of crazy.
No, I agree. I already have a couple classmates that I don't think are practicing anymore.
Yeah.
And I've 1 year in, but no, it's really huge to hit 10 years. That's awesome.
Yeah. It flies by too. Like now that I think about it, I was like, man, has it really been 10 years? Because it kind of seems like it's only been like maybe 2 or 3 years. But yeah, it goes, man.
And then it's been the same setting, right? The 10 years?
No,
like
so
area?
the first 3 years were I did a lot of PRN, so it was a lot of SNF, acute, outpatient, workers' comp, so a little bit of everything, just because of where I lived. Colorado, Denver, Colorado, for one, it's just super saturated with tons of PTs, PTAs. So it was a real struggle to try to find full time positions that were actually worth the time. But and then I did contracting, technically travel therapy within the state of Colorado, and then that's how I landed my job that I'm at, and I've been there for over 7 years.
Nice.
So a long time.
Well, that's awesome. Well, let's get into the plan of care. Sorry if you hear my dog in the background. I think he's trying to break in, but
is he trying to scratch through the door again?
He's trying to dig himself in through the dig himself.
Yeah,
through the wall.
It was funny because me and Ken recorded at my house earlier this week, and my dog tried to get in, and he did this nice little gentle one time.
Right.
Dink,
his was like a nice little.
And then
hey,
just laid
can
down.
You let me in. Mine is trying to dig a way through China to get here.
There
Anyways.
You go.
All right, so let's start with you want to do plan of care?
Yeah, we'll do the plan of care if you want to.
So let's start. What is the plan of care?
The plan of care. So the plan of care is usually established at the eval. So the patient comes in, usually sees the physical therapist, and they will do their full eval. They will establish their plan of care. Depending on how the physical therapist wants to set up this plan of care is generally up to them. If they know that they're going to work as a team with PTAs, they usually set it up more generally So where I work, it's more generalized. So let's say I have a basic musculoskeletal patient, something like a total hip or total knee. Usually, the physical therapist that I work with or that I have worked with will be like, here's your plan of care. It looks like this is a generalization because this is how it's set up for me. It'll be like perform thorax, neuromuscular rehab, manual therapy, therapeutic activities, and that can go down the spectrum of all those CPT physical therapy codes.
Mm-hmm.
And if that is all that is in there, that is what I have to go off of. So I can work within the realms of they just said thorax and they didn't say specifically I want thorax with, specific range of motions, then I can basically do whatever I want, or we can do whatever we want. It can be as broad as that, or it can be as restrictive as the physical therapist will literally put in exactly what they want done in the plan of care. So something like an example with that total knee arthroplasty, they'll say, hey, patient needs to work range of motion, active, passively, within, I want the goal to be 120 degrees, right? Or I want zero extension. And if there is anything outside of that I want to do, I cannot do it. I will have to go back to the therapist and I will have to say, said patient could benefit from X, Y, or Z. Or if there's something that I don't think is appropriate for the patient that I want off of the plan of care, and then I go back to my therapist and be like, this patient is really not appropriate for X, Y, or Z.
As far as like seeing the difference between someone who's fairly vague and someone who's like super specific, do
Yeah.
the PTs that are specific, do they update the plan of care more often? Do you feel like, or is it kind of the same?
So the one that I work with right now, he'll update it. He'll like so I'm going into work tomorrow and we're talking about a new patient and he specifically wanted me to do some manual therapies for said patient. And so, I talked to him and I said, okay, I'll make sure that I do that. And then outside of that, I'll perform everything else that he has in the plan of care. So if it's just like basic thorax or manual, other manual stuff that I want to do, I can. So
Yeah, I feel like for the most part, since I've only really worked in outpatient, I think they're all almost vague for the most. I mean, at least
Yeah, I was
I
about
worked
to
under one
say.
PT for so long as well.
yeah,
I feel
Well,
like
and I've
most of
worked with a
mine are vague.
couple. I would just say in general, most of the locations, if they work with PTAs, they like to leave it vague.
yeah,
So you do have a little bit of freedom, but like mine, literally, a lot of times will include like their sentence will be like, we'll co-treat with physical therapist assistant, and we'll perform, exercises and da 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 da, and but not limited to, or and they literally will put like modalities, and so like they literally leave it so broad.
yeah.
Um, Now, have you ran across where someone has been so strict, but how do you like? And you're like
Like, how would you
they've
approach the
you're like
PT? Like,
I'm almost, yeah, like almost too strict to the point where you're like, how do I approach someone to be able to kind of get them to stop making the plan of care is almost too strict, that I've got no wiggle room to work based off of how they're feeling that day, or improve them without having to go back every single time to the PT.
So that's a great question, and I think this will come up for a lot of new grads too. Um, this is good to know, and I actually wrote this down. So if there's not enough wiggle room within the plan of care, it basically comes down to you at some point within your work week, you need to cut out some time to sit down with your physical therapist and you need to get on the same page of here's my education level, this is what I can handle, this is what I might need a little bit of help with, and this is what I don't feel comfortable doing. So it would be great if you give me resources or you teach me how to do said things. But it basically comes down to being able to have that discussion with your PT. And um, I've been fairly good about in probably the last maybe 8 years of my career going up. And when I work with a PT and be like, hey, this is who I am, this is my education, this is my background, this is what I'm good at, and this is what I'm not good at. Like, this is what I might need more help with. Do you mind, helping me learn? And then usually with that dialogue, you start to gain trust within that team role, and that physical therapist, you can be like, hey, I wish that you could write the plan of care this way so I can have some room to either make modifications, um, either regress the patient, or I can progress the patient to where I see fit. And usually that
Hmm.
goes over pretty well. Every single physical therapist that I've worked with, to be honest, has been pretty receptive. I think it's just coming to them as opposed to being reactionary. Well, you'll be like, well, said therapist thinks I'm not capable, he thinks I'm stupid, or all this. It's like, no, you have to go advocate for yourself and just be like, hey, like, I'm really good at this and I can show you.
Yeah.
Like, if you need me to show you, I'd be willing to show you. Another thing is too, if they just coming from, like, if you want a therapist to write the plan of care so general, you need to show them that you know the
Capable.
research. Yeah, you know the
Yeah.
research. You're staying up to date on the latest research protocols, and that you're constantly learning, and they want to know that.
Yeah, I couldn't agree more with you. I feel like a lot of the times when PTs make the plan of care really strict, it's because they don't know your skill set yet.
Hmm.
And they do feel a little bit more comfortable when, you go to them and you talk about what you can and cannot do, what you don't feel comfortable. Or also, like, they feel like you'll come to them if they put something that they want you to do. That if you're discussing that with them, they'll feel more comfortable of like kind of leaving it open. So that way, if they do have a question, they know you're going to come to them versus just try to do it type thing. So I couldn't agree more with that. I've
Yeah,
only
that's what I
seen
was
like
gonna
maybe
say.
one,
Like as far as like opening
one
up those
strict
channels
PT.
of communication, I feel like go a long way. And I know that's what I did when I first started with my PT. Like if he did a lot of mobs for his plan of care, and it's like, hey, I haven't done knee mobs or shoulder mobs as much because I didn't really learn them in school. And it's one of those things like if I didn't bring that up, then it's like, where should I go? Should I just try to do it even though I'm not comfortable doing it, or just let the PT know like, hey, I haven't done this technique or I'm not as versed with this technique. So I think opening up those channels of communication go a long way. And like you said, like they build the trust. And usually most PTs are open to that, like they're receptive to it. Then they'll either teach you the ways or they'll kind of work around what you can do, and then they'll teach you those methods like down the road. But
Yeah.
I agree 100%.
When I first started working out in the hospital that I was at, the PT that was formerly there, it was interesting. We had that dialogue. He was a new grad right out of DPT school, and I had been practicing for, I think, almost 3 or 4 years by then. And we were just getting to know what our skill sets and what we're good at. And I told him, I was like, hey, I'm really good at inpatient acute care stuff. And he just straight up told me, he's like, I haven't really had much exposure to it. Maybe you could help educate me on certain topics. And I just told him, he was specializing in some PRI techniques. And I knew nothing about it. And so we just traded
PRI, sorry.
yeah, it's a
PRI?
postural.
I'm not sure what that
Yeah,
is.
it's Postural Restoration Institute. It's its own
Okay.
whole thing. You can look it up. Uh,
I didn't mean to cut you
yeah.
off, but I wasn't
No,
sure
no,
what
you're
PRI
fine.
was.
No, you're fine. It's own kind of like way of approaching the nervous system and asymmetrical um,
So this is like a
or
whole
as
nother specialty kind of.
yeah. I mean, they do have like specialty certifications for it. It's definitely interesting. It's about um, asymmetrical patterns in the body. Your heart's on more of one side of the body, liver's on
Hmm.
more of the right. You got a diaphragm where it connects lower on the right than the left, and it pulls us certain ways, and we're all asymmetrical. Yeah, it was like this
Which makes
rabbit.
sense
Yeah, it is this
in a way.
rabbit hole of like
We're gonna have to look into that.
how to reposition people, but I knew nothing about it. So I was learning through him. But it was interesting. So I'd learn his skill set because I had to know if I was taking over his patients and he was giving them these interventions and I didn't know what the heck they were, you know,
Yep.
I
Yeah.
had to learn it. And so I ended up taking courses and whatnot too, so I was more versed in it. And then other things too, like I taught him more of the acute care stuff and what to do, but it
It's funny that you kind of
Speaking of
mentioned that
the,
because I literally had the same thing just happen with my PT, like legit. Where it was, I had like my review, 60-day review, but it was actually way past 60 days. But they were talking about certain things, and I was talking about like that was one of the things that I had brought up of being good at doing is just communicating with my PT and learning from her. And then even later that night, she came to me, and she's newer. She's like a year and a half out, and she never really did a lot of STM work. She did a little bit, but you know, the location she was at did a lot more dry needling if possible,
mm,
or tool assisted STM, but like just not really too much hands on. And we went over some stuff, and I went over showing her kind of how I like to do mine and the positioning of it. And
mm-hmm,
she now has literally changed how she does some of her manual technique to legit match because she's like, oh, I like that better. You're right. I can get better pressure. But I want to say one of the cool parts on it, she came in one day and she kept getting just spasms within her upper trap. And she's like, yeah, they dry needle, they get it, but like it's just not going away. And she's like, I might ask you to work on it. I was like, that's fine. And so one day during lunch, I helped her and I worked on it, and it went away. Like she's like, I haven't since that happened. She goes, she hasn't woken up with a episode at all. And she
nice.
goes, I've literally had dry needle. But the nice thing is when you actually get to do something like that in practice with your PT and they actually can feel what you're doing, the trust for that plan of care also comes with that too, because then they understand and can feel exactly you know, what you're doing. And so then they're a little bit more, like you said, a little bit more open on that plan of care.
Yeah.
Yeah.
speaking of like dry needling, that's it's hard for us to take courses on that. But like, what do you recommend for, like you were saying, like the PT does certain techniques that you took courses to help yourself understand those technique better.
Hmm.
Like, do you feel like that's the route people should go if their PT does those techniques? Do you think they should try learning from their PT or just kind of communicating with their PT like, hey, is there ways I can do so that I can help you with your plan of care and just kind of progress this a little faster, I guess?
I think the first thing that I would do is actually just approach the PT and be like, hey, can you teach me said techniques? And if they're like, yeah, you only need to know a couple of these, you don't need to be like, specialized, or you don't even need to take a whole course on this stuff. I can teach you, let's meet up before or after in between patients whenever you got time. It's only going to take, X amount of time. That's where I would start. So I definitely approach the PT first and see what they want you to do. Now, if you're a complete nerd like me and you want to know why you're doing this stuff, I'm never not going to recommend people take continuing education or certs because it's just going to make you that much more competent. So when, you get underneath another PT or under the same PT, you can explain to them why you're doing stuff. You can advocate, be like, hey, this technique really works. This other one doesn't. And then you can also better educate the patient too.
Yeah, I agree.
I remember when I was going through clinicals way back when, I was doing IFC on a patient, not knowing that the patient had I think he had a master's in electrical engineering, and he was asking me what this was doing. And I just remember like blanking in my head of like physiologically what is going on. And I was like, I need to go back and I need to reread that section of the
Brush up a
modalities.
little bit.
Yep. And
In all fairness, though, what's the odds of you getting someone who has a master's in electrical
I
engineering
know, right? And he was
the
just
one
like,
time, right?
yeah, it's the one time. Of course, it's on, clinical too. So I'm just like a student, like, I don't know. I just know that it works, right? It's
Right.
You're
like,
like, the
We
studies have
just know
shown it
that
works.
stuff.
yeah. So I would always say like keep up to date. If you feel like you're really struggling to know a section of like the plan of care and how to treat people, whether it's neuro, muscular, cardio, palm, integumentary, or the various systems, and you don't know why you're doing this stuff, you probably need to go back and take some, continuing education, or you need to do the research. I mean, point in case, I mean, you guys are going to be able to see this, not that people are listening to this, but like, I got my patho book because there's some times where I'm just like, what? And I go back and you just revisit it and you're like, okay, cool.
And we can
Yeah, I
confirm
found
he
myself
did
doing
show
that.
us his patho book. It looked nice and worn, and
Right, like actually
So
used.
this
had some
is
notes
so
in there.
my
Some pages coming out.
my OG one was the white one. This I actually ordered because I lost my old one, and this is like new and update. And it's kind of funny because I think this was like 2018, and it's got big old virus on the front. And I got it during COVID. I was like, this is kind of ironic a
Wow.
little bit.
Right? Yeah, you see certain
They
things
added it
sometimes, and
to it
you're like,
already.
Yeah,
Like I definitely found myself doing that when I first started more often. Like I would treat a patient with like a certain diagnosis, and then I would go to my notes and be like, all right, what do my notes say real quick on this like
yeah,
type of patho, and then okay, I would go treat. I think because of our setting, we see the same thing over and over again. You kind of
mhm,
get into a rhythm, but
yeah,
no, it's definitely good practice to always, oh, okay, this is what I have. Let me see what my notes say. Kind of brush up on your stuff. That way you don't forget. And kind of explain the easy things too. Like the better you understand it, the better you're going to be able to explain it to patients on why you're doing what you're doing.
yeah.
yeah.
And I think the more you explain it to patients too, it sets in your brain a little bit more too,
Hmm.
of just like, it's not something that you're gonna always have to go back and look up because you're discussing it
Yeah,
quite
it's
often.
that teach back method, right? If you ever
Oh
make
yeah, I'm
patients
a
do
big like
that.
I learn by teaching back.
Yeah,
Yep.
yeah.
Which does not work, by the way, because sometimes me and Ken actually learn the exact same way, where we learn by quizzing other people.
Hmm.
As you quiz and you test and you learn that way, kind of asking the questions. Both me and Ken learn that way, which is not great to work with someone sometimes who learns the exact same
Because we
way.
both want to
'Cause,
quiz each other.
yeah, both of us just want to quiz each other. And we're like, no, it's my turn to quiz you. No, 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 I'm going to quiz you. And you're like, wait, you're like, I need someone to answer these. So,
Yeah, and like kind of going back for step to step of how I approached my plan of care, like I read the PT's eval or the last treatment note because sometimes they do update the plan of care and it's not just off of the eval. Uh, Another good thing to know is your short-term and long-term goals if they're in there, if your PT does that. And I just, familiarize myself with the contraindications and the precautions. And then I'll go through medication checklists, all that stuff. But I tend to have time to do a chart review on patients real quick. Sometimes I don't, but I would say that's the way to do it. Do a quick chart review, read the last note that whoever treated said patient, and then go from there.
For your contraindications, are they typically listed in the plan of care? Or is it more like this is their patho, you're more expected to know them?
At this point, I would say more than less. It's more the expectation to know them, and as opposed to like they're listed. Sometimes they'll be listed, and sometimes the physical therapist that I work with, he'll just verbally tell me, and then I'll make a note about it. But most times it's actually they're not listed, and I need to know what I'm doing. So it's not like you're getting your hand held for this stuff. It's you go in there and you need to know what you're supposed to do and what you're not supposed to do.
And I think that's another good point to like bring up the communication with your PT. Like if you're not sure, either if you can try to find it yourself, if you like to brush up on it yourself, that's one way. And then another way is communicating with your PT like, hey, are there certain things I can't do? But I mean, I wouldn't also ask every single time because then it's like you're expected to know after you've asked a couple times.
Yeah, and there's going
Uh,
to be things that are out of your control as well, which come up. Patient comes in later in the week and is presenting with signs and symptoms that just don't add up. And then for me, because I work in general supervision, my PT is just, I have to call them if something doesn't feel right or something doesn't present right. And if I can't figure it out myself, I have to call them and be like, patient presents with X, Y, and Z. I also work in a hospital, so I do have access to physicians. If I think it's really bad, I can pull them in. But I can tell you, I've had that happen. I have something weird happen probably every 5 to 6 months where patient's doing really great. Next time they come in, case in point might be like a total knee patient where they've ripped their quad, and you have to know what that looks like. Somebody fractures their patella.
I have not seen that.
Compression fractures. Yeah, I've seen a lot of weird stuff. People tearing their bicep tendons because they're not following their protocols and stuff. Yeah.
We had somebody come in and I'm like, I didn't get the PT because that don't look right. I'm like telling him, and I'm like, I'm not gonna say it, but if you walk in there and you feel like it is, then you can say it. But she even asked me like, does this look right? I'm like, nope, but I'll be back.
Yeah, and it's always, for me, I tell them, I was like, it could be X, Y, or Z. I'm not saying that's what it is. Like the likelihood of it, if it's pretty well, I can see that
like
tendon's not, the presentation, if they have a pop eye, or you can tell that their proximal, the head has detached, or the distal head has detached for said bicep. You can be like, yeah, I'm pretty sure. And then I will contact my PT and be like, they're presenting with this, and be like, yeah, send them to ER, or I already sent them to the ER, to be honest. Send them back to their surgeon, wherever you need to send them.
Check in.
You need to know that stuff. And for all the people going through PTA programs or new grads, like, keep up to date on stuff, how to test stuff, special test or just observation skills or assessment skills,
All right, well, with that, we'll wrap up today's episode. Thank you so much for listening. Today was, remember that, part 1 of 2. Friday, we'll be back with Joe talking about the advocacy for pay, whether you're a new grad or already a practicing therapist. Be sure to follow us on all our socials, on Instagram, YouTube, as well as join the Discord. This is where you're going to find Joe and a lot of other PTAs just kind of communicating, getting to know each other, and just helping each other out. So be sure to tune in to that. And until then, we'll catch you next time. Take care. The information in this video or podcast is not intended nor implied to be a substitute for professional medical advice, diagnosis, or treatment. All content, including text, graphics, images, and information contained in this video or podcast, is for general information purposes only and does not replace your professors or a consultation from your own doctor or healthcare professional.